Hello, I'm Peg Bolgioni, Communications Specialist with Rutland Regional Medical Center, and I'd like to welcome you to Window on Wellness. We are pleased to have Dr. Darius Seidler, Pulmonologist and Critical Care Physician with Rutland Regional Medical Center, joining us to discuss lung cancer awareness and their comprehensive lung cancer screening program. I'll be back with Dr. Seidler after this message from Rutland Regional Medical Center.
Welcome to Rutland Regional Medical Center. We are Vermont's largest community hospital with 37 specialty clinics. Healthcare organizations have always fixed people once they're broken, but at Rutland Regional Medical Center, we do more. We provide nutrition counseling, weight loss help, smoking cessation classes, all the things that help the community and individuals stay healthy. And we do it all with this promise: to listen, to respect, and to care, always.
Welcome back to Window on Wellness. I'm very pleased to have as my guest today Dr. Darius Seidler. He is a pulmonologist and critical care physician with Rutland Regional Medical Center. Dr. Seidler, welcome to the program.
Thank you for having me.
So I think we're going to dive right in, and I know that the purpose of the show is to talk about lung cancer screening awareness and the importance of it. So I think we'll begin with, what is lung cancer?
So basically, at its sort of most basic, it's really an abnormal collection of cells. So it's when normal cells in the lung eventually grow out of control, they essentially mutate, and they sort of lose their ability to die or sort of repair themselves. Mm-hmm. So you basically get a bunch of cells that just keep on growing, and they eventually grow into other tissues, into blood vessels, and could also spread through the bloodstream into other organs or the bones.
Okay, and so what are the symptoms of lung cancer that people should really pay attention to?
So here's the tricky part. So most people are actually completely asymptomatic, especially in the early stages, which are actually the most treatable stages, but people may not have any symptoms at all because the lung really doesn't have any pain fibers other than at the very edges of it. Mm-hmm. And the symptoms that you may look out for are sometimes very nonspecific. This can be cough. A lot of people have cough, especially now that the flu season is around. People tend to get a cold and could cough at any time. You have smoker's cough, so people cough from that, and hence it's really not a great symptom for lung cancer in of itself. You do get some of the later symptoms, which tend to be already in advanced stages, which can be coughing up blood, for example, if the cancer invades into a blood vessel. But you also could get pain if it invades, for example, into a bone, or if it has spread to the bone, and people may get back pain, rib pain, or other symptoms related to wherever the cancer has spread at that time.
So really, I mean, it's what you're saying is that for this to be symptomatic, you really have to be in the advanced stages, and sometimes the symptoms can mask they're confusing to some people, like they think it's something, but it's really something else.
Correct. Unfortunately, that's true, and as you may attest, almost everyone gets a cough during the season at some point, and so it's a very non-specific symptom. Mm-hmm. And yes, unfortunately, the later stage symptoms, one that I didn't mention was, for example, weight loss or things like that, really present themselves once the cancer is usually advanced.
I know that most people think that smoking is the only thing that causes lung cancer, but that is not true. Can you explain some of the other things that cause lung cancer?
Absolutely. So smoking accounts for the majority of causes, around 80%, and others that are maybe less quantified but that have been associated with cancers are things such as radon exposure, accounting for around 2%. There's asbestos exposure for people that had, for example, worked in a shipyard or in the Navy or did a lot of brake work. And there are certain other chemicals that people can be exposed to that may increase the risk of lung cancer, such as formaldehyde, sometimes arsenic, and there's really a big list of things that could potentially cause cancer.
Okay. And what about secondhand smoke?
So again, this is kind of hard to quantify. We do know that, yes, smoke exposure, any smoke exposure really can increase the risk for lung cancer. But, secondhand smoke, it depends on, if we are in a big room and you smoke way over there, that may not give me a lot of secondhand smoke exposure. But if people are in confined spaces and very close to someone that keeps smoking in the same room, then yes, that could also increase the risk for lung cancer.
What about environmental factors, air quality, what's in our rivers and streams? I mean, is any of that attributable to lung cancer?
Well, again, it's kind of hard to quantify,
Right.
but people have associated nickel, or sometimes people in occupations where they're exposed to hard metal dust, they may have an increased risk for lung cancer, but it is sort of harder to quantify. I think the most known one would be asbestos, aside from radon and radiation exposure is another one, and yeah, that usually in combination also with cigarette smoke, then multiplies the risk for cancer.
And I think people sometimes forget that lung cancer is still the #1 causing cancer, correct? I think that's still accurate.
Absolutely, yes, yes. It is unfortunately a very deadly cancer, in part because it's discovered fairly late. Most lung cancers are discovered in stage 3 or beyond, where surgery is not possible anymore. So, but yes, it is more deadly than breast cancer, than, for example, prostate cancer or colon cancer. If you want some numbers, for example, the 5-year survival rate for lung cancer is such that 7 out of 10 people die after around 5 years of diagnosis, versus 4 out of 10 people for colon cancer. So again, significantly more deadly, and breast cancer is around 2.5 people out of 10 after 5 years.
If a person quits smoking, will their lung tissue regenerate?
So their lung tissue per se will not regenerate. If you think of the alveoli and the little bubbles that are way at the end, so I think some of that lung tissue is permanently lost. However, I think there are a lot of things that can help when you do quit smoking. You, for example, regain some ciliary function. Ciliary or cilia are really sort of little hairs that are around our airways, and cigarette smoke is directly toxic to them. So they don't function well, and that's why a lot of people have the smoker's cough, where they just produce a lot of mucus all the time, and that's not cleared efficiently. So after you quit smoking, a lot of these cilia regenerate and resume their job. The other thing that you can see is that you have less mucus production after you quit smoking. A lot of people that quit smoking may find that within the first month they actually have a little bit more junk they're coughing up, which is essentially their cilia coming back into action and resuming their work, and the lung kind of being cleaned out. But after that, you really decrease your overall amount of sputum production, you decrease the level of inflammation. So if airways are inflamed and angry, so to say, they can also be a little bit swollen. So you have a tighter airway that once you quit smoking, the inflammation goes away, the mucus goes away, and the cilia do their job again. So I think it really helps the airways the most, in a sense, and they will regenerate and sort of will heal back to their normal function.
Is lung cancer hereditary?
So that's a complex question. There are some genes that are associated with cancer, and there is certainly something we take note of if someone has a family history of cancer. Really any type of cancer, but specifically lung cancer, because that usually indicates that there may be some type of predisposition to, for example, not repair your tissue well enough. Some people have great repair mechanisms, others don't. It may be something that you have, random mutations that can happen quite a bit, which are not hereditary. But I think if you smoke, you basically favor mutations because you put a toxic onto the cell or a toxin onto the cell, and it will change its behavior, and it then grows out of control. But yeah, the genetics of lung cancer are somewhat complicated. There's not one gene at this point that we can, that we know about, although there are several that are associated with that, and there are, some in the sort of familial cancer gene.
Okay. So, so why, I guess we can't emphasize enough, why is it important to find it early, lung cancer?
Really because the treatment at the later stages is much more difficult. And again, I think we could, I would say, almost easily treat lung cancer, if it's in its early stages, where, for example, a stage 1 lung cancer, that's sort of only in one little focus, and you could actually see that on one of our graphs here that we provided. It really is just in one focus, and you could reasonably cut it out and essentially be done with it. Versus you have your stage 4 cancer, if that's spread, you cannot cut out all these little pieces because most patients would not survive that, the surgery itself. And hence, finding it early really provides the greatest chance for cure and also for response to chemotherapy, to radiation therapy, if that's something that is needed for that type of cancer.
And so what are the different types of lung cancer?
So there are a number of them. We sort of generally put it in two big groups, into non-small cell lung cancer and small cell lung cancer, and then there are other groups, carcinoid and many other cancers. But non-small cell lung cancers account for around 85% of all lung cancers, and your small cell lung cancers are anywhere from 10 to 15%, and then all the other cancers making up the rest.
And so what is the mortality rate for somebody that was able to get in early to have it treated?
Yep. So in a stage 1 lung cancer, you, again, referring to one of our graphs, you can essentially have a cure rate of, that people that survive after 5 years of 80 to 90%.
Oh, wow.
And that's really from all causes. So, if they get into a car accident, then unfortunately they are counted in the people that did not survive, but which is pretty good. 80 to 90% is very good after 5 years. Versus a stage 4 cancer, it is less than 10% after 5 years. And you really can see in the graph that you have this progressive decrease in survival as the stage progresses, or as you're staged higher.
So why don't you tell us a little bit about the comprehensive lung cancer screening program at Rutland Regional?
Okay, so I think it's a very exciting time right now that we have that tool available to do that type of thing. I mean, we did have obviously chest X-ray, CT scans for a long time, but finally, or several years ago, there was a big study that was done using more than 50,000 patients that looked at how efficacious is screening actually, and can we make changes in terms of catching it early, treating it early, and hence decrease the mortality in cancer. So the people that are dying, which, as you mentioned earlier, it is the deadliest cancer of all the groups together.
Right.
So we can really, with a low dose screening CT scan, again, I want to emphasize that this is a low radiation dose CT scan, so you don't get a large dose of radiation, and we scan the patient. It's very quick, takes about a minute or two in that CT scanner, and we're looking for nodules as small as 1 millimeter. And if people are, if they qualify for that program, it's by Medicare criteria, and generally people should have a smoking history of 30-pack-year smoking history, which means either smoking 1 pack per day for 30 years or, for example, 2 packs per day for 15 years. If they're current smokers and or have quit within 15 years, and if they're anywhere from 55 to 77 years old, they will qualify for this scan, and if they're healthy enough to also undergo therapy and treatment. Because this population really are people like you and me that maybe smokers or maybe past smokers that are obviously at highest risk for lung cancer, and hence screening those people makes the most sense to help catch things early and treat them.
So for people to get involved in this process, do they have to be referred to by their primary care physician to do the lung cancer screening?
So yes, I think almost any physician could make that referral, but it would typically be the primary care physician, or if they're seen in the lung clinic, then it would be one of us. It's sort of part of our daily thing that we do, that we screen people if they're eligible for this, because it really makes a big impact on their survival. So yes, either if the patient brings it up to the primary care physician and says, look, I'm a smoker, I'm worried about this, or I'm a past smoker, I'm worried about this, is a very effective way to also raise the alertness on part of the primary care physician to say, oh yes, maybe we should refer you to the lung cancer screening program.
And the insurance will I think I meant the insurance covers this if there is a referral, correct?
So that is correct. If you meet the criteria that are preset, and then Medicare will cover that. Yes.
Do you think, and I'm sort of kind of looking out into the future here, with the vaping that's going on with young people, do you think that there'll be an increased incidence of lung diseases or going forward?
So probably yes. We don't have a ton of data on that yet to really say absolutely. I think right now the most worrying part about the vaping is that it's sort of a gateway into nicotine addiction, because you vape stuff with fun flavors but still have nicotine in it. And I think a lot of what has been true so far is that some people that started out vaping eventually will smoke. And vaping in of itself has sort of some other issues that it can cause in the lung. So I think I would not be surprised to see 10, 15 years down the road that we see the long-term effects of vaping. Again, at this point we don't have enough studies to confidently say, yes, absolutely, that's what will happen, but I think it's a pretty good guess to say yes, that
wow,
doesn't have a good impact.
Yeah, well, there's a lot of discussion right now about vaping, and I know that I thought it was seen as something that would be a deterrent to smoking for people that were trying to, quit or do less of it. The vaping seemed to kind of satisfy that craving, but
and it does, and that's where I think there's some controversy in the medical community as well. For example, the British Thoracic Society does actually say, okay, if you use it as a smoking cessation aid, we'll look the other way and let you vape if it helps you quit the cigarettes. And I think that's that is fair. I think though that it's a very different person that maybe has smoked for 40 years and now they're trying to quit, and they use that as help in quitting, versus people that just starting out and just get addicted to a substance that they may eventually get from cigarettes.
Yeah. Well, let's just hope that people pay more attention, that there's more studies, and then they can come up with some more conclusions about that this is not a good thing. It's dangerous. And you said it's a kind of the gateway to addiction, smoking addiction.
Correct.
So, the other thing I know with our lung cancer screening program, it's quite comprehensive. I mean, you're walking through a number of steps, with the respiratory therapists, with the nurses, and there's a lot of supports. And there's also options for to enroll in tobacco cessation programs, and so those are all good things.
Right. I mean, I really I have to say I'm new to this community, but I'm very impressed with my team and the work they have been doing. And I think if people are really serious and are interested in quitting smoking, there are a lot of ways that we can help them, whether that's patches, lozenges, gums. There are some medications out there that we can use, but and sometimes just coaching as well. I mean, we do have a tobacco cessation class, and I think there are a lot of ways that can help people to quit smoking.
Well, thank you, Dr. Seidler, for being here today. Really appreciate it. And so now we're going to go live to the Pulmonary Center at Rutland Regional Medical Center to view an actual demonstration of the lung cancer screening program.
The referrals made for the lung cancer screening program by the primary care physician, the patient's primary care physician, or our pulmonary physicians. The appointments are scheduled through the pulmonary clinic. Once the appointment is scheduled, the patient arrives. They come for what's called a shared decision-making appointment. We are required to have that appointment prior to the CAT scan being done as part of an insurance requirement.
Hi, come on in. I'm Kim. I'll be working with you today. We're going to get your height, your weight first.
So when a patient arrives, we do what's called a Tamamagi score. It's a lung cancer risk score that we do to provide a risk assessment for whether or not they are appropriate to participate in the program. The score involves getting information about a brief history, whether or not they have a history of lung cancer in their family, whether or not they have a personal history of cancer. We ask some basic questions about height, weight, age. The patient has to be, in order to participate in the program, between the ages of 55 and 77. They have to have a smoking history of at least a 30-pack year. They have to be willing and able to participate in the program and undergo possible procedures like biopsy or surgical intervention. They have to be non-symptomatic for lung cancer at this point in time. Lung cancer is the leading cause of cancer deaths in the United States. And the reason, it's not that it's more prevalent, it's just by the time we find lung cancer, it's in a more advanced stage. So the goal of the program is to screen and scan early so that we can find smaller, nodules at an earlier point to provide earlier intervention.
So after the shared decision-making appointment, we go through prior auth department to make sure that the patient will have this test covered. We then schedule the CT scan. The patient will arrive. There's no contrast needed, no IV needed, and the patient is put on the scanner, and usually only on the scanner table for maybe a minute or two. The technologist will ask them to hold their breath and let it out, and then they're done. They can go home. People say they're scared of the CT machine itself. It's often confused with an MRI machine, which has a longer tunnel, and you're in that scanner for a longer period of time. For the CT scanner, you're basically traveling through a donut, and it is really much, much shorter of a scan. You're only in the machine for a few minutes, and you make a couple of passes through. The technologist will ask you to hold your breath and let it out, and then you'll be all done. So we're looking for a very small nodule. They can be as small as 1 millimeter or 2. We have a computer program that aids in picking up these nodules because this CAT scan is less radiation than a usual CAT scan. So when we think about medical radiation, we want to use the smallest amount that we need to do what we want to do. With the aid of a computer program, we can give less radiation to pick up these nodules. They're not the same as a diagnostic CAT scan, which you might get if you came to the emergency room for symptoms of pneumonia. We are just looking for these nodules here. So the computer-aided diagnostic piece works with the radiologist to pick up nodules that we would normally not see because of the minimal amount of radiation that we're using. Because the computer program is able to aid with this, we can then classify these nodules based on a standardized system that's used across the country and help risk stratify patients so that they know when their next follow-up scan should be. Once we have the report back from the radiologist, we then look at the interpretation, and if the patient doesn't need to come back for a year, we call them and let them know their results. We send a copy of the results to the person who ordered the scan, and then we just put them back in to be rescanned in 12 months. If something is needed that is more follow-up, either because the nodule's a little bit bigger or something else is concerning, follow-up could be as soon as 3 months or 6 months, and we would speak to the person's ordering provider to let them know so that they can have that conversation. This sort of program is important because it's not the first scan that's going to help save lives. It's the follow-up scans, so we know exactly what patients' lungs look like, and if something new crops up, we can be ready to attack quickly. The first scan is a baseline, and any nodules that were already present are just going to be tracked. We don't want patients to avoid coming in because they're worried about what they'll hear, because whatever is there is there. We want to catch it before it's symptomatic to give people a better chance at survival.
Please continue watching Window on Wellness on PEG TV, Channel 15, and on demand at pegtv.com.